We were talking about this whole business. I want to tell you a couple of things that I didn't mention last time. Well, one of them I did, but now I have pictures. I told you that if someone starts taking anabolic steroids, eventually what's going to happen is your testes are going to shrink up. Well, this is testes pre and post anabolic steroids use. These are rat testes, so you know they weren't that impressive to begin with. But still, this is experimental anabolic steroid use and showing what happens to the testes. And then let's get into estrogens, and then we'll come back to the androgens for a second after we do ovaries. Okay, so ovaries. Ovaries are easy. Because they're just like testes. They're basically this, what is it? The same homologous embryological structure. So we're just going to rebuild this for ourselves. Okay, so I know you just saw it, but I want you to build it anyway. Just the process is useful. So if we are going to end up with production of estrogens and oogenesis, right? What organ does this whole story start in? Hypothalamus, exactly. Okay, and the hypothalamus makes what relevant hormone to the story? GnRH. Are you guys starting to feel a little bit more confident about your hormones? Yeah? Feeling a little better? It just takes a while. Okay, and then GnRH goes where? Anterior pituitary. I think you've heard that before. And then I want to tell the estrogen story first, okay? So the anterior pituitary makes what relevant hormone to estrogen secretion? LH. And LH, it's actually kind of complicated, but I'm going to simplify it for you. LH definitely goes to the ovaries. It goes to a certain place in the ovaries. And it causes, ultimately, production of estrogens. But let me tell you how it really works a little bit, and then I'm going to tell you that I don't usually try to trick you about this. Here's what really happens. What really happens is this, guys. LH goes to certain cells in the ovaries, and it causes secretion of androgens. But then females have boatloads of these enzymes that can do the conversion of androgens to estrogens. So ultimately what you're going to end up with is a whole bunch of estrogens. But please remember that, of course, estrogens are converted androgens. So in women and men, you make androgens first, and in women, you convert almost all of them to estrogens. Good? Okay, so, but ultimately, I mean, it hardly matters for the phys story unless something goes wrong, and then it does matter. Ultimately, what you're going to do is get estrogen secretion. And then remind me of the solubility of estrogen so we can talk about the feedback mechanism. It's lipid soluble, exactly. So estrogens feed all the way back to the hypothalamus, and then they also feed back to the anterior pituitary. Okay, good? So it's pretty much the same as testosterone, right? Okay. All right, so now let's do the other functionality of the ovaries. Well, there's actually more than one. Ovaries are a little bit more complicated than testes because in addition to having to produce gametes and also having to produce hormones, they also have to be able to support a pregnancy, right? So there's another layer of complexity on it, but we'll get to that in a second. So if we are ultimately going to cause oogenesis, what's the relevant anterior pituitary hormone? FSH, exactly. And it goes, again, to certain cells. You don't have to worry about the names of them. And then, of course, you do oogenesis. But you only do oogenesis if you have estrogens. Same kind of thing that you had with testosterone and spermatogenesis. Good? Okay, now, how do you know when you just actually went through the maturation process of an egg, right? And you have one that's ready for ovulation. What you do is the same thing. Whenever you do oogenesis, you also produce inhibin, right? And then inhibin ends in IN, so its solubility, water soluble, so it can feed back where? Yeah, it feeds back to the anterior pituitary, and it only shuts off the production of FSH, not LH. Good? So it's the same story, right? Okay? Pretty much the same story as you learned before. So let's look at the functionality of estrogen and talk a little bit about oogenesis, and then I'll bring in progesterone. Okay, so just so you know, with the female reproductive cycle, I am not doing it justice. I'm giving you a surface knowledge of the female reproductive cycle. When I took phys, we spent 4.5 weeks on the female reproductive cycle because well, it's really complicated, and I think that my professor was a dirty old man. He just really, really, really wanted to talk about it. I'm serious. Like, all you had to do was wear shorts, and you totally passed the class, right? Shorts, front row, totally cool. Okay, and his name was Dr. Gross. It was. He was. Okay, so what do estrogens do? Well, estrogens, in addition to being responsible for part of the female reproductive cycle, they also are responsible for the development of the female primary sex characteristics. And I didn't show you guys this picture last time because I forgot that I had it. But remember when we talked about the whole Mullerian ducts and Wolffian ducts, right? This is the picture that shows you how this occurs. So we'll just go back through this for just a second. So the Wolffian ducts are the lighter pink ones in the back, and the Mullerian ducts are the darker pink ones in the front. Okay, this is the sexually indifferent or gender indifferent stage. And then, of course, remember how we said that you get to be a male, is that you, on the Y chromosome, you have differentiation and degeneration of the Mullerian ducts because of Mullerian inhibiting hormone, right? And then you get a surge of testosterone that causes the continued development of the male reproductive tract. Now, if you are a female, what's going to happen is you are going to, the default is going to develop something like this, but to go from here to here and to have correct development of the female internal reproductive tract, you need estrogen. Right? You need estrogen about 6-7 weeks post-implantation. If you don't have that, what you're going to get is female external genitalia, but you won't have a uterus or fallopian tubes. That's what's going to happen. So it's responsible for female primary sex characteristics, right? And then female secondary sex characteristics, which are the ones that change at puberty. What was your question?
So do the Wolffian ducts go away when it makes it female?
Yeah, they do go away when it makes it female, but it's not a separate hormonal process. It's actually the presence of estrogen which will eventually make them go away. Yeah, you don't have to have an extra hormone in order to do it. It's kind of like they were on their way to going away anyway, right? So with a male, you have to turn off the female ducts on purpose, and then you have to actively support the continued development of the male ducts with testosterone. Good? Okay, so female secondary, so these are primary sex characteristics, just putting everything in the right place, right? And it just pretty much stays there until you hit puberty. And then when you hit puberty, what's going to happen is you get your secondary sex characteristics, which are not in this picture. But it's just think about a girl going through puberty, right? You're going to get bone mass and muscle mass growth, not as much as testosterone would cause, but you still get that, right? And then you get all of the other change. You get the change in body fat deposition, which makes you go from being shaped like a kid to shaped like a woman, right? Body fat deposition stops around the middle as much, and you get it more in the hips and more in the breast. You get breast development because of estrogen. And then you get the other changes. Of course, estrogen definitely feeds back on the brain. There is no denying it. You get that, and then you get axillary and pubic hair growth and all of those kinds of things. The thing that estrogen does not do is it is not at all relevant to sex drive. Sex drive is exclusively androgens. So the tragedy that I would like to talk to someone upstairs about is that you can definitely get pregnant without ever having a sex drive. We need to talk to someone, right? Management, please? I'd like to talk to someone. They're necessary for the female reproductive cycle, including oogenesis, and estrogens are actually converted androgens. So I'm going to do a quick and dirty job on progesterone because its feedback mechanism is really complicated. Basically, at certain points in the cycle, the presence of estrogen is going to cause you to produce progesterone by a little positive feedback loop. I won't make you draw that one, though. Because it's actually very different at different points in the cycle. So you can't just like say the female reproductive cycle is like this, because it's actually, a whole story that's 28 days long. Here's what progesterone does. Here's a quick way to understand what progesterone does, big picture. Progesterone is how the ovaries boss the uterus around, okay? So what the ovaries are going to do every cycle, right, 28-ish days, is they are going to start with maturation of a single oocyte and ultimately oogenesis, right? And then ovulation, right? Okay, so that happens in the ovaries. And of course, I'm going to be the female reproductive tract. These are my fimbriae, right? Okay. And this is my uterus. I don't know what the hell this is. But, so what's going to happen is I just ovulated over here, and then you do what's called a courting of the oocyte, which is because of progesterone. Here's what happens. You woo, 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 and you're trying to suck it in here. So what happens is you suck it in here, and then fertilization generally happens up here if it's going to occur. Okay. Fertilization is, of course, egg and sperm coming together. The thing that you need to understand about fertilization is it is not pregnancy. Fertilization doesn't change anything physiologically about the woman's body. So fertilization can occur and occurs up here. Here's what the ovaries are going to tell the uterus, right? So as the ovaries are about ready to ovulate, they're going to start producing progesterone in large quantities, right? And progesterone is pro-gestation. Progesterone is like an animal in here. Progesterone is pro-gestation. It tells the uterus to do what? What does it tell it?
Get ready.
Get ready, right? How does the uterus get ready for a possible implantation? It thickens the endometrium, the lining of the uterus. It's going to be fine. Nobody's going to die, right? So it's just... What?
We can see it flying on the screen.
Oh, you can? Oh, I see. Okay. So, okay.
That's the fertilized egg.
Come here! Okay. So, okay. Focus. So it tells it to get ready. But here's the deal. The fertilization and the implantation do not happen simultaneously. They are days separated. And I thought it was 4, but apparently it's 6. And she would know. So what happens is the fertilization can happen up here, and then it takes up to 6 days for implantation to occur. Okay? So you need to have progesterone just hold on to some hope. Progesterone level stays really high. It stays high before ovulation and after ovulation in case an implantation occurs, right? And if an implantation occurs, it should stay high during the entire pregnancy. If an implantation doesn't occur after X number of days, your body goes, maybe next month, right? And the progesterone level drops, and then you slough off the lining of the uterus, and then the woman menstruates. And then you start the whole damn thing over again, right? Progesterone is lipid soluble, as is estrogen. They both feed back on the brain, and a lot of women have some impacts associated with estrogen and progesterone. Does that make sense to you guys? So that's sort of progesterone's big picture understanding. We're going to come back to progesterone when we talk about the morning after pill. We'll talk about that in just a second. So it maintains the lining of the uterus in preparation for pregnancy or until no implantation occurs. Okay, there's 2 other hormones that are relevant. Go ahead.
So, like, if a woman is trying to get pregnant, like, can she take progesterone if that's, like, what she's having an issue with?
You can, and sometimes do supplement progesterone, but it's usually when implantation occurs.
I don't know, with IVF, you do progesterone before.
Progesterone before.
To build up the lining.
To build up the lining.
You could, I mean, it depends on if there's a problem with you trying to conceive naturally. I mean, if there's a problem, you could probably supplement with progesterone. I don't know. I'm not a doctor.
Yeah, I think that they do supplement with progesterone, but not always. I mean, there's a million different reasons for infertility, so I doubt that there's one way to treat it. But let's say it is a reasonable thing to consider. That's as much as I can say with it. The other 2 hormones are Inhibin, and we already did this one, right? And then one more that you only release during childbirth, and it's called relaxin. And what relaxin does is relaxes the smooth muscle and the connective tissues. Really in here, because you've really got to get a cantaloupe through a nostril, right? So you got to get it out of there, right? That's a design flaw. But it also makes your body feel as if all of the joints are really loose, right? Like I didn't go through labor. I have a heart problem, so I can't go through labor. But my best friend who did said that when this stuff comes on, it feels like if you threw a ball, your arm would go with it. And you're just kind of like one of those floppy things that's outside the car dealership, one of those, right? So that's what relaxin does. It sounds pretty pleasant, honestly. So the question is, can you reconstruct the chain of hormone secretion that starts in the hypothalamus and ends with oogenesis and estrogen secretion? And the answer is yes, because you just did it, right? Okay, so you can do that. Now, let's talk about something that is kind of controversial. It gets a little less controversial when you understand it, but not necessarily less. I mean, not so much that your mother-in-law would agree with you about it, but RU486, mifepristone, is one of a big category of drugs. There's a bunch of different levels of them. Just pick this one. That, depending on your political leanings, you might call the abortion pill or the morning after pill. So let's talk about how this is used and what it has to do with physiology. Okay. So keep your politics. It's fine. We can disagree, but I want you to understand the physiology of it. So here's how this works. So remember I told you that fertilization and implantation are separated by a matter of days. Nothing in the woman knows that fertilization has occurred unless and until implantation occurred. So between the time you had sex, potentially, and the time you got pregnant, there can be up to a week. Does that make sense? So you don't get pregnant when you have sex. You get pregnant days after you have sex. Okay, so that means that let's talk about a situation in which it's slightly less controversial, like rape. So a woman goes into a hospital after she is sexually assaulted, and one of the things that she can choose, she doesn't have to, is to take this drug, a series of drugs, actually more than one time that you have to take it. And what it is it's a progesterone antagonist. So I want you to figure out what it's going to do. What's a progesterone antagonist going to do? What? It blocks the receptors, and what's that going to do? Yeah, so it wouldn't allow for implantation. From a physiological perspective, this is a pregnancy preventer. Okay, doesn't work dramatically differently, just so you know, than an IUD. So a lot of people are completely outrageously upset by this, but they have a copper IUD. IUDs do not prevent ovulation. The Mirena kind of does, but that's not its primary mechanism. It prevents implantation. Okay, so that's what those do. So I know that we can be very, very emotional, but it's really good when you're consistent, right? When your emotion is consistent with the actual facts. So what happens here is you potentially have a fertilization event. You have no way to test whether a fertilization event occurred, right? It's not possible. So what you can do is you can get a medication with a series of it, like you have to take it more than once. It will cause sloughing of the lining of the uterus so the pregnancy can't occur. So physiologically, this is a pregnancy preventer. Now, the issue comes in that, of course, certain people believe that a baby is a baby from fertilization. Just to put it into your database of information, only 50% of fertilization events end in implantation. Okay, so if you've had three pregnancies, you've probably maybe had 6, fertilization events. I mean, although it's not for an individual, it's collectively, but we're just looking at it that way. Okay, so you can think about that. The other part of the issue is that if usually with this one, I think it's a 72 hours that you're supposed to take it in, but some of them you can take higher levels of progesterone antagonists for longer periods of time, like up to 6 weeks, and they can cause chemically induced pregnancy termination. It's a different use of similar medication class. So that's where some of the controversy comes in. These used to not be available in Utah at all, and now they are available in Utah. It's definitely not going to be offered to you very readily in Utah, but they are available. Go ahead.
You said the IUD prevents implantation. Is this because of the nature of the structure or the nature
So
of...
you want to know something interesting about the IUD? They actually don't know. We know that it works, and we do not know why it works.
And we use copper just because that's what...
No, we use copper because copper is the metal that seems to prevent implantation.
Okay, so it is
best.
partly copper.
Yes, the metal is part of it, right? So you stick it up there, and then you don't get pregnant, and you're like, that totally worked. But they actually do figure out, if you assess the hormones, that your progesterone and estrogen levels are still cycling normally. And there is no reason to assume that ovulation isn't occurring. It's just implantation.
They tried different shapes, though, and it was like...
Yeah, they tried different shapes, and they've had some terrible results with years and years ago with those.
So shape and...
Yeah, it's like a little T in your uterus. It's a little T, and it prevents implantation. And then there's the next round. The next round of them are a combination of preventing implantation, and also to a certain degree, although we don't know how much, they prevent ovulation. The Mirena ones, which is a plastic one, it's a plastic tea stuck up there, but it's impregnated, no pun intended, with a bunch of hormones that small quantities will actually probably prevent ovulation much of the time. So it prevents ovulation most of the time, but it also, if ovulation occurred, it will also prevent implantation. That's how those work. And it's much lower levels of hormone than oral contraceptive.
Well, how did they figure out copper?
I have no idea. That was back in the
Let's just try your
1970s.
It worked!
Where they all died, but nobody got pregnant. So that's like 100% success rate, right? Single one of us got pregnant. I don't know the history of that. I know it was in the 1970s. You know that birth control, oral birth control, only was in 1969, I think. Yeah, 1969, and then other forms of birth control after that. So I don't know that particular history, but that's an interesting question. Anyway, so now you guys have something to argue with your family about, right? I'm just kidding.
Are there like side effects to taking this?
Oh yeah, it's terrible.
Are there repercussions to like using it as a form of birth control?
Yes, repetitively using this as a form of birth control is really, really high levels of progesterone and can screw up your system. It doesn't screw it up quickly and sometimes not permanently, but this is really uncomfortable. So we are talking about dropping your progesterone really, really quickly. It's going to be the worst menstrual experience you've ever had, times about 10, especially if your lining was relatively thick. So this is not a pleasant mechanism to, and a lot of people think that it's so painful because you're actually terminating pregnancy. No, what you're doing is you're dropping your progesterone level really dramatically, and then you're sort of aggressively sloughing off the lining of your uterus all at in one fell swoop. So this is not, a comfortable mechanism of avoiding this. So anyway, go ahead.
Is progesterone associated with postpartum depression?
I don't know.
Because they always talk about the big drop off of hormones after birth.
I don't know. That's a good question too. You gotta look that up and teach me. Okay. All right. Okay, so chemical class of hormones, androgens, estrogens, progesterone, they're all steroids. MIH, inhibin, and relaxin are peptides. Let me tell you guys just one little story, and then I'll tell you one that the girl in the last class told me. 2 stories. I got 2 stories. I don't really want to talk today because I've got something on my mind, but it's fine. We'll do this. It's fine. Let's just do it. Okay, so one thing is I want to tell you about this particular story. Just keep this in mind as I'm talking. Okay, so this is a case study that I used to teach out of when I taught this human genetics and human reproductive class. This is a story about a couple and a woman. She was in a marriage, and her husband consistently told her that he wanted bigger breasts. He wanted her to have bigger breasts. I don't know why the hell she married him either. I mean, but consistently told her that. So what she started doing is she got an estrogen cream, because remember, estrogen is lipid-soluble, right? So you can rub it. And although this is really not an effective mechanism, she started rubbing estrogen on her breasts. And it actually can cause a little bit of breast tissue development. It's not going to be really dramatic. It's not going to be like a cup size or anything. So she was doing this, and she wasn't sharing it with her husband. And then they would have sex. For months, right? And then, well, what do you think happened? He developed breast tissue. He got gynecomastia, developed into breast tissue, which is just absolutely the most perfect response ever. I always say that he should have been more specific about it. Right? Go ahead. Oh, they did. They did, but hers developed minor, right? It's just a little change. No, it's totally true. This is a case study. It's actually really common for any kind of hormonal cream to cause responses in the other person. There's 2 other sort of examples of this. So a change in him would be very noticeable. A little bit of gynecomastia in a male would be very noticeable. In her bra's a little tighter. It's not that big deal, right? It's like a little bit. It's like, oh, I'm feeling slightly hormonal and my boobs are a little bigger. It's like, every month that happens. So that's one. The take-home message here is I want to entertain myself and also don't mess with your reproductive hormones. And then the student in the last class told me that she works at a compounding pharmacy. And so with compounding pharmacies, they make a lot of like reproductive supplements. And so they prescribed this guy testosterone cream for whatever reason. There are a million reasons why you might want to take that. And he was rubbing it into his chest, but then he also had a newborn that he was bonding with, right, holding it. And the newborn's genitals started to increase in size, and they didn't. So the take-home message here is we all need physiology, don't we? All of us, to know how to not jack everything up. So he was like bonding and not wearing a shirt, right? And then, yeah, skin to skin contact, right? And then one other little thing is that she didn't tell. I mean, I don't think she had any way of knowing that. They just eventually came in and said, I don't know why this is happening. And then when they figured it out with the doctor, they told the pharmacist what's going on. Probably should have been wearing my shirt. I'm sure that was on paperwork, right? Don't snuggle with your infant, the testosterone all over your chest. I'm sure it's in there somewhere, but you're like, I don't have time to read that. So one last little tidbit about androgen, anabolic steroid supplementation. Because of this right here, do you see why it's really, really important if you've got a dude who's doing anabolic steroid supplementation for building muscle mass, that in addition to taking the anabolic steroid, he needs to know enough phys to take an estrogen blocker? Do you see why? Because once you get boatloads of this, you're going to start to get conversion into this, and then he is going to have massive pecs with nice breasts on top. That's what he's going to have, right? And then he's going to have boobs, and he's going to have little bitty testes, right? This is all poor planning, right? I had a short-term solution to a long-term problem, and he ends up, I got boobs, I got little bitty testes, I got great big muscles, and I'm pissing everybody off. It's terrible. Okay, so now that's all. That's all the hormones. Woo! So the last little part is just these. Now, I'm not going to test you over these yet, but I want you to leave a place for them on your endocrine table, because at some point in your career, you're probably going to learn about these. And then there's a couple of them that we are actually going to learn later this semester in detail. But I don't test on these yet, okay? And sometimes not at all. You can put them on there if you want to. But let me just tell you a little bit about them so you will know more in the future, okay? The thymus gland, does anybody know where that is? Oh, by the way, if you didn't download the most current set of notes, then this is in a different place. Okay, so just skip past signal transduction mechanism. What? Oh, okay. It's after this. Okay, so the thymus, where's your thymus gland? Anybody know? It's kind of on top of the heart, sitting on your great vessels right there. The thymus produces a hormone called thymosin. And thymosin is responsible for maturation of your T cells, part of your immune system. That's why they're called T cells, because they mature in the thymus. And by the way, somebody missing a thymus would have a bubble boy disease, SCID, a severe combined immunodeficiency syndrome. So you might learn that at some point in your life. The pineal gland, you have learned before if you've had anatomy, right? The pineal gland is, on the back part, and the pineal gland is responsible for producing melatonin to help regulate your circadian rhythms. But what really happens is the hypothalamus is its boss. The hypothalamus says, it's nighttime, and the melatonin goes, I got it. And the pineal gland goes, I got it, and produces melatonin. Good? Okay. Then there's some more. The digestive tract produces ghrelin, which makes a lot of sense because you produce it when your stomach's growling. It is actually the hormone that's responsible for hunger. The stomach produces gastrin, which helps with digestion. The heart produces a hormone which we are going to learn later this semester. It's called atrial natriuretic peptide. And what it does is when your blood pressure is really high, your heart releases a hormone that tells your kidneys to pee, to drop your blood pressure. That makes sense? It's how your heart talks to your kidneys. Good. And then your kidneys release several. Two of them are EPO, erythropoietin, which talks to your bone marrow to tell you to make red blood cells. And then calcitriol is like a hormone / vitamin D kind of thing. The placenta, when implantation occurs, and you want to know if you're pregnant, you pee on a stick, the placenta produces HCG, which is human chorionic gonadotropin. And that's the most common way to test for pregnancy. Don't waste your money right after you had sex, though, right? Because physiology can save you. Those things are expensive, like $25 a pop for a good one, right? Because you don't get it at the dollar store. Don't get your pregnancy test at the dollar store. That's a bad plan. Don't get your condoms there either, as a matter of fact, right? Or else you might need the other one. So yeah, you $12 to $25. So what happens is you pee on the stick, and when implantation occurs, right, then you start releasing a hormone that says implantation occurs, which is called human chorionic gonadotropin, and it is produced in larger amounts as the placenta actually gets bigger. So sometimes it even takes like a couple of weeks before you actually produce large amounts. Oh, you want to know something cool about twins? If you got a bunch of twins stuck in there, you're going to produce massive quantities of HCG. Your HCG levels are going to be, yeah. Did you have twins? No? Oh, they thought she might have twins? Oh my gosh. Oh, me too. I have a friend with triplets, and every time I look at her life, I think, I might actually kill myself if that occurred. No. So and she just constantly looks like shell-shocked, like, oh my God. Somebody stop. Have a cocktail. She's like, I can't, I'm breastfeeding. I'm like, oh my God, I don't even know what to tell you.
More than two, because you've only had 2 boobs. I mean, like, that should be the limit.
And she had them naturally. And she's already got 2 older kids, and she's in her 40s. Because when you start to get into your 40s and you're almost done with your reproductive age, you start to hyperovulate. That is not fair. So anyway. So that's HCG. Adipose tissue also produces leptin. Leptin is a hormone of satiation that tells you when you're full. So it's so weird that adipose tissue produces this. I'm not sure how it gets a signal or anything. So we've just figured this out within like the last 5 years. There's a medication now. So what it happens is when you eat, your adipose tissue releases this hormone called leptin that tells you that you are satiated, you're full. But some people don't release very much of it, and some people aren't very sensitive to it. So with like life-threatening obesity, there's a medication that actually increases your leptin amount. It's called leptoprine. But another good way to eat less is just to eat more slowly so that you have time to release leptin, right? So you know that people who eat slowly tend to eat less, right? And in part that is because leptin actually feeds back and tells you that you're satiated. But you can also use it to your advantage, because at Thanksgiving when there are mashed potatoes, how quickly do you eat the damn mashed potatoes? You guys shove them in your face hole before the leptin kicks in, right? Somebody's going to eat them later, right? I hide them. I hide mashed potatoes around the house. And they're like, why are there mashed potatoes in the beer fridge? And I'm like, nothing. Shut up. You have your advice. I have mine. Okay. All right. So clinical connections. Let's start doing these. So we're done with hormones. Woo! And we've already learned all of the endocrine disorders too, but now I'm going to teach you how to categorize them, okay? So we're not learning any more disorders. We're just trying to figure out how to categorize them. So with the categories for endocrine disorders, they can either be a hyposecretion, which is what? Too little. Hypersecretion, which is too much. Or responsiveness disorder. And the responsiveness disorders are not directly because of the hormone levels. They're because of the target cell. Either the receptor doesn't work, or the signal transduction mechanism doesn't work, right? Or the hormone is not metabolically able to activate what's going on there. Does that make sense? So with those, sometimes they look similar, but you wouldn't treat them the same, right? So do you see that a hyposecretion disorder and a hyporesponsiveness disorder might have similar symptoms, but you wouldn't treat them the same, right? With a hyposecretion disorder, you'd add the hormone back. With a hyporesponsiveness disorder, it wouldn't make a damn bit of difference if you added the hormone back. Make sense? Okay, so now let's get this relationship. This is higher level thinking. Hopefully you will get it and it will make total sense to you. This is the kind of thing that I expect an A student to be able to understand. If you don't get it the first time, then you might have to just work a little harder until you get to an A. But it's just a logic thing. Here's a logic thing. Do you see that if left untreated, a secretion problem can cause a responsiveness problem? So let's think about this. So let's think about like type 2 diabetes. Type 2 diabetes, okay? With type 2 diabetes, it starts out as a what problem? Hypersecretion of insulin, because of your Dr. Pepper problem, right? Hypersecretion of insulin. And then if you let that go for a long time, it's going to cause a what regulation? Down regulation, and then a what responsiveness? Hyporesponsiveness. Do you see the progression there? So do you also see with endocrine disorders, it really behooves you to treat them as quickly and as aggressively as you can, you know, obviously responsibly. Here's another one. What if you have a male who has a chronically low levels of testosterone, right? Chronically low levels, and doesn't do anything to treat it, okay? That chronic low level of testosterone secretion can cause what regulation? Upregulation. And then when you start treating them with testosterone, the normal level might not work because you had a what? Hyperresponsiveness, right? So you had a hyposecretion that can cause an upregulation of receptors, which will make you hyperresponsive. Does that make sense to you? So that's one of the reasons why, like, endocrine disorders are freaking intellectually challenging to understand and to treat, because it matters not just what's happening, but when did you catch it, right? That makes sense? And sometimes you can flip it back, but that's not instantaneous either. Go ahead.
Is it always opposite? Like if you have hyposecretion, you have hyperresponsiveness?
Probably. I never memorize it. I just think it through every time because I don't know what it does. I just like have to tell myself little stories. I don't memorize anything pretty much. So I think that's right. Like a hyper would cause a hyperresponsiveness, and hypo would cause a hyperresponsiveness. Yeah, I think it's always opposite. Okay. All right, so let's talk about treatments just briefly. So if you have hyposecretion, it depends on the chemistry of the thing that's there, how you add it back, right? So we already talked about that. So we already talked about this conceptually too. Which one do you think is easier to treat, a hypo or a hypersecretion? Hypo, right? At least theoretically, because you can add it back. So what do you do with hypersecretions? Well, you have to assess why you're hypersecreting, right? Is it a tumor? And if it is it benign or malignant? And if it's benign, is taking it out going to cause more problems than leaving it in, right? So if it is a hypersecretion disorder, you can choose radiation, surgery, chemotherapy. For instance, with thyroid tumors, in addition to surgery, quite often they do radioactive iodine, which just goes right here and ends up kind of blasting the rest of it there. So they do that in combination. Now, the other thing you can do is you might need to use an antagonist. Like, remember I told you have estrogen antagonists. You don't have antagonists for every hormone. But when they exist, you can use them for hypersecretion disorders. Or theoretically, you could figure out how to block the hormone synthesis, but we almost never have the capacity to do that. Okay? And then let's go back to hyposecretions. With a hyposecretion, you, if it's a lipid-soluble hormone, the OIDs, steroid thyroid hormones, right? You have a lot of possibilities of how to add it back. You can usually do it orally because it doesn't get broken down by the digestive tract. You can inject it, or you can do it sometimes topical creams or patches. You can do those kinds of things. So that's why there's so many possibilities for instance, birth control, right? You can do birth control patches, you can do slow release little injections, right? You can do oral birth control, all that kind of stuff. And those are mostly progesterone, estrogen combinations, or one or the other. Thyroid hormone, you can add it back orally as well. Does anybody know if there's a thyroid cream? I bet there is. Don't know. Never looked into it. Theoretically, there could be a thyroid cream, and now I wonder if there is one. Maybe it just doesn't work very well. So what about a peptide or a protein hormone? Insulin, the only effective way that we've found is to inject it. They have practiced with some like nasal inhalers because it bypasses the digestive tract, but peptides don't absorb very readily. So you're going to have an absorption problem there too. So generally insulin is going to be injected. And then growth hormone is a peptide as well. And so if you had like pituitary dwarfism, you could inject growth hormone. You couldn't take it orally because it's a peptide. That makes sense? So that's treatments. Okay, so now we're going to start talking about the secretion disorders. And so the objective here is to be able to categorize all of the disorders that you've learned into hypo and hyper, or secretion, or responsiveness. So before we get into that, I need to teach you primary, secondary, and tertiary. People get really confused by this. It's not very hard, I promise. So let's just talk conceptually first, and then we'll do thyroid as an example. So where are you? Okay, so you know several examples of hormone chains that are 3 hormones long, right? Lots. Most of them that come from the hypothalamus, not all of them, but most of them. Okay, so I've got a hypothalamus hormone, an anterior pituitary hormone, and then a third endocrine organ hormone. Okay, so I want you to think about thyroid for just a second, and then we'll draw it on the board. So if I had hyposecretion of T3 and T4, which are your thyroid hormones, right? Does it make sense to you that the problem could be here at the thyroid, or it could be here at the anterior pituitary, or it could be here at the hypothalamus? Does that make sense? Okay, so depending on where the problem occurs, you can categorize the, let's say, hyposecretion first. You can categorize the hyposecretion as primary, secondary, or tertiary. And what you do is you always start where you saw the symptoms, right? And then you check that first, okay? So if you had low levels here, but high levels here or normal levels here, then the problem probably occurred right here, right? Okay, so let's do it with thyroid hormone. You ready? Okay, so this one you will definitely have to be able to do, the thyroid hormone chain. So if I'm talking about thyroid hormone regulation, T3, T4 regulation, where's the story start? Hypothalamus, okay? And the relevant hypothalamus hormone to this story is what? TRH, okay? TRH goes where? And anterior pituitary secretes what relevant hormone? And TSH goes where? And you make what in response? T3 and T4. Okay. So this is how the feedback mechanism is supposed to work, and then we'll break it and see what happens, okay? So the feedback mechanism, solubility, here, lipid. So it can go all the way back, and it can also go, good? Okay, so now let's talk about hyposecretion disorders. I want to talk about a hyposecretion disorder in which the problem is with the thyroid, okay? If the problem is with the thyroid, tell me what you can expect about the level of T3 and T4. Low. Does that make sense? So the thyroid cannot make enough, so this level is going to be low. But now ask yourself, if the problem was here at the bottom, what could you expect about your levels of TRH and TSH? They would be normal to high, because what are you losing? You're losing feedback. You got it? Okay. So they'll be normal, but if you let it not be treated for a little while, they're going to creep up because they're going to try to stimulate the thyroid. Does that make sense? Okay. So a primary hyposecretion would look low, normal to high, normal to high. Okay. Now let's look at a secondary hyposecretion disorder. Secondary hyposecretion disorder, the problem does not occur here, it occurs here. But it would have the same symptoms, right? It just wouldn't have the same lab test. So either way, whether it's primary, secondary, or tertiary, you would come into to your doctor, you'd say, I've gained so much weight, I'm really exhausted, and my hair is falling out, all that kind of stuff. Like, oh, let's see what happens. So if it's primary, these are low and these are normal to high. If it's secondary, what can you tell me about it? It's going to occur not here, but here, right? So what can you tell me about your levels of TSH? Low. And your levels of T3 and T4? Low. And your levels of TRH? Normal to high, exactly, depending on how long it goes on. Make sense? Okay. And then the last thing is, what if it's tertiary and the problem is actually occurring in the hypothalamus? Then same symptoms, right? What can you tell me about your levels here? Low, low, low. Yeah. Okay. So that is primary, secondary, and tertiary. Now, quite often, they don't treat tertiary any differently than secondary because it's really hard to manipulate that hormone level. It's really low and it's got the blood-brain barrier. But it does at least tell them that something's going on with your hypothalamus, which might be relevant to other things in your health. Does that make sense? What was your question? Somebody read that?
You start with primary scan.
Always start where you see the symptoms. Yes. Start where you see the symptoms and then move backwards, right? Does that make sense? So it's like Occam's razor, right? You're always going to find the simplest example, the simplest answer first. And then if that doesn't work, you can go, okay, well maybe it's more complex, right? If that doesn't work, it's going to be more complex. But always the simplest answer first. Thyroid problem, something's wrong with your thyroid, right? Now, why would you care? If you had secondary hypothyroidism, you would not only add, for instance, T3 to the system, you would also add TSH to the system to try to stimulate the thyroid. So you try to stimulate the thyroid, but then because it's not being stimulated immediately, you add T3 to the system, right? To try to get relief of the symptoms. Whereas you wouldn't do that if it was a primary. disorder. Does that make sense? So it's easy. You just start from the bottom, right, and then move up. Okay? So those are primary, secondary, and tertiary disorders. So let's talk about some primary disorders. So what could be going wrong at that bottom organ? So if you have a primary hyposecretion and you've had it your whole life, it might be genetic, right? There's just something wrong down there and you can't actually make the levels of hormones. And it doesn't have to be thyroid, just so you know. Or does it make sense to you that if I had an iodine deficiency, would it be categorized as a primary, secondary, or tertiary hyposecretion? Primary, because it's actually, it's easy to treat, but it's still primary, right? The problem is still occurring at the thyroid. Just doesn't have enough of the precursors to the hormone, right? That's still a primary hyposecretion disorder. It's just an easy one to treat. Everybody good with that? Okay, so dietary deficiency of the precursor to the hormone, iodine deficiency, can cause a hyposecretion of what? T3 and T4. And then quite often autoimmune diseases. Your immune system just being a jerk and deciding to destroy something it wasn't supposed to destroy, okay? So autoimmune disorders quite often cause primary hyposecretion issues. Why? They really like glands. In addition, a lot of times they don't destroy two different things at a time. Now they can cause secondary, but it's more likely. So for some reason, your immune system likes to make mistakes and destroy your thyroid gland. It also likes to make mistakes and destroy your adrenal cortex and your pancreas. Those are usually primary hyposecretions that have to do with autoimmune diseases. So let's look at each one of them. Primary adrenal insufficiency is also called Addison's disease. Do you remember what that's a hyposecretion of? Two different categories of hormones. Cortisol, all of the glucocorticoids, and aldosterone, right? Okay? And remember, it causes hypoglycemia and poor stress tolerance, and JFK had it and all that business. Okay, so let's talk about that one. That one, they actually know that most of the time when people get it, it's because of the immune system response after TB exposure. So this is how they think President Kennedy got it. And he was in the war, and he went overseas. I think it was Korea. Wasn't he in Korea? Is that the right time period, I think? Right before. Seems like it's the right time period. He's like not old enough for World War II. I think it was, what?
Wasn't he 40 in the early 60s? Like
Yeah, that makes sense, doesn't it? I suck at history, honestly. I didn't listen to any of it the entire time I was in class. And also, I did history in Texas. They taught Texas history like 4 times.
Yeah.
They totally did. And also, I only got up to World War II. I'm pretty sure something happened after that, but I have no idea what it was. Right? I don't know. It's a bunch of coaches teaching history in their coachy shorts. So basically, I was an idiot. I tried to educate myself. Isn't it fun when you get to be an adult and you realize that holes in your education? You're like, oh my God, everybody's smarter than me. It's terrible. Okay, so I tried to remedy it. So anyway, so what they think, and occurs quite often, is an exposure to tuberculosis causes you to make antibodies to tuberculosis. And for some reason, those TB antibodies like to attack your adrenal cortex. And so quite often, a TB exposure, even if you never got tuberculosis, because you don't have to get the disease in order to make antibodies to the disease, right? You don't actually have to have the symptoms of the disease. So as a matter of fact, I don't think JFK ever had tuberculosis. I think he got exposed to tuberculosis. Anyway, so it attacks your adrenal cortex, and then you end up with this. So a lot of times TB later on, as if you didn't have enough problems with TB, right? Later on, you're going to get Addison's disease sometimes. Go ahead.
It was World War II.
Oh, World War II. Okay, World War II. There we go. Thank you. We're all educated now. Okay, so now the next one. So type 1 diabetes mellitus. So with type 1 diabetes mellitus, they used to say that it was genetic as you got it as a kid, but I should probably change those words. I will next time. It's usually a genetic predisposition to an autoimmune disease. So now they think even when you get it as a juvenile, it's autoimmune. But you can have a strong genetic predisposition, so it like runs in families. But people don't get it at infancy. They get it like 5, 7, 10, right? So what happens is your immune system, because of an exposure to, we have no idea what, produces antibodies which attack your pancreatic islets. And then it causes a primary hyposecretion of what? Insulin, yeah. And then Hashimoto's disease is last, and Hashimoto's disease is hyposecretion of what? T3 and T4. Yeah, that's the one that we were talking about. And that's autoimmune. It usually hits in your 30s to 50s-ish, more often women than men. Although, didn't somebody ask about this in this class? I can't remember. Yeah, so, and the other thing is that it's the one autoimmune disorder that has come up, I think you asked about it, Chase, that is not sort of disproportionately female.
Yeah.
So I don't know about that one. That one seems to be pretty evenly distributed among the genders, but most autoimmune disorders are more likely to be in females, as is Hashimoto's. Okay, so those are all primary hyposecretions. So again, the major reasons for primary hyposecretion: genetics, dietary deficiency, autoimmune, right? Okay, and then secondary hyposecretions exist. They don't look any different than primary, they're just treated differently than primary, right? They have the same symptoms. Tertiary also exists, but they're usually treated like secondary. So you've got secondary and tertiary. Okay, and then let's talk about hypersecretions. If you have a primary hypersecretion, you're making too much from here, it's usually because of a tumor. And the tumor can be benign or malignant. And depending on that, that's how you treat it, right? You either like try to get it out of there because it's going to kill you, or maybe decide to leave it in there. So sometimes they are autoimmune. I'll tell you one in just a second. So these primary hypersecretions. Acromegaly is a primary hypersecretion of what hormone? Growth hormone in adulthood, right? And pituitary gigantism is the same thing in childhood. But I want to teach you about one weird little example. I think I taught your class about it before, but there is one hypersecretion disorder that is autoimmune. And that's that weird one where you have a TSH mimic, TSH agonist. So you get exposed to something, nobody knows what, and then what happens is you have a TSH agonist. It's an antibody, right? Your immune system made it to try to protect you from whatever, but it actually finds its receptors on the thyroid gland, the same receptors for TSH. So here's what I want you to do to think about this autoimmune hyperthyroidism, which is autoimmune Graves' disease, right? An autoimmune form of Graves' disease. And they think most Graves' disease is autoimmune. I mean, you can have a tumor too. But I want you to think about the levels of hormones that you would see, okay? If it was this autoimmune hyperthyroidism, what would you see about levels of T3 and T4? Really high. What would you see about levels of TRH? Low. And levels of real TSH? Low. So you'd have low, low, high, and the real TSH would be really low. But if you could assess for the antibodies, the antibody level would be high. And that's part of like how you can detect that you've got this sort of autoimmune hyperthyroidism. That makes sense? Okay, so that's hyper secretion. Secondary and tertiary hypersecretions also exist, and it just changes the way that you treat them, or the way that the surgery that you do, or whatever. Similar symptoms. Okay, so now let's look at responsiveness disorders. Responsiveness disorders are, let's say, to simplify, that there's nothing wrong with the hormone level that's causing the problem, although we can see with type 2 diabetes it actually starts out as a hormone level problem. But the target cells are not responding normally to normal levels of hormone, okay? So the target cells, maybe the receptor doesn't work, or maybe you can't start the signal transduction pathway, or maybe you can't activate the hormone. For instance, testosterone has to be activated by its target cells. And if the target cells don't activate it, even though you have high levels of testosterone, you're going to have symptoms of low testosterone. So that's a responsiveness problem, okay? So, or you can have too few receptors, okay? So let's go back to this one that we talked about before. Testosterone or androgen insensitivity. We talked about this one last time, right? And that's the genetic one in which your receptors for testosterone just don't work. And so this is a hyporesponsiveness disorder because your levels of testosterone are just fine. A hyporesponsiveness to all androgens, but testosterone specifically. Good? Okay, so that's one we talked about. That was the developmental disorder in which you have an XY fertilization that ends up anatomically female, at least externally. She doesn't have a uterus or vagina. She has a vagina, blind vagina, no uterus, no fallopian tubes. Just ends at the cervix, is where it ends. And then type 2 diabetes mellitus is a hyporesponsiveness problem. It's a hyporesponsiveness of what? Insulin. and often as a result of what regulation? Downregulation. Good? Okay. So do you see that all of this stuff is like the step after memorization, right? This is the step of understanding that I want you guys to get to. It takes a little while. That's part of the reason I'm going to put off your test until a week from Thursday. Okay. Now, this stuff, if you can't get this, it's probably not going to flunk you on the test. But if you can get it, it'll help keep your grade at a B or an A, right? And just so you know, I'm not guaranteeing a B or an A for anybody, but I'm just telling you that when I write that 10% of questions, I am thinking about the A and B students who I think that they can get them. But, you know, 80, 85, 90% of the questions are going to be, do you actually know this stuff? And this is like, can you figure this stuff out that I didn't teach you in this exact example, right? That's my concept of like a higher level student. Right? Okay, so hypersecretion. So we did the hypersecretion. Wait, we did the hyperresponsiveness. Oh, the only one, I'm not going to ask you about this one, but just to make everything parallel, I needed to put a hyperresponsiveness example in there. This one doesn't make a whole hell of a lot of sense, and there aren't very many hyperresponsiveness disorders. But I will tell you, this one exists. So first off, do you remember that both thyroid hormone and epinephrine have metabolic effects? Do you remember that? Right? Thyroid hormone increases the metabolism of all tissues, and then epinephrine increases skeletal muscle metabolism and dumps nutrients into the bloodstream, right? Okay, so here's the deal. If you don't treat hyperthyroidism, Graves' disease, for a really long time, then what happens is it causes upregulation of your epinephrine receptors and a hyperresponsiveness to epinephrine. Just impacting your metabolism for so long in one way can have these other unpredictable metabolic responses. And why does it matter? Because it means that a person who is not properly treating Graves' disease, if they get a fight or flight response and get epinephrine dumped into the bloodstream, their heart rate doesn't go up a little. It goes up massively and stays up for a really long time. Because even in response to normal levels of epi, you have massive fight or flight responses, and it's really hard for them to calm back down. So, but I don't ever ask about that one because the story isn't like super logical, right? But I couldn't like do hypo and hypersecretion and hypo-responsiveness and not a hyper-responsiveness. It just felt wrong. So, okay, so for each disorder, you need to be able to categorize it. Now, can you categorize it as primary, secondary, or tertiary if I don't give you some fake data? No, I have to tell you that, right? So if I wrote a question like, okay, a person comes in and they have like weight gain and hair loss and they're really, really lethargic, your brain goes, oh, hypothyroid, got it. And then I say, and their hormone levels are low levels of T3 and T4, low levels of TSH, normal to high levels of TRH. Now you can tell me whether it's primary, secondary, or tertiary hypothyroidism, right? Secondary, right? So 2 up is secondary. So I have to give you that in order for you to answer those kinds of questions. Like you can't tell unless somebody like measures something. I mean, the doctor couldn't even tell, right? They all look the same until you actually measure the hormones levels. Okay. Everybody okay?
Are these pretty easy tests? Like, are these just blood tests that you can run?
This is really easy to test. Generally speaking, in my experience, and things do change, even when you're pregnant, you'll get these 2 tested, right? Just because they want to make sure your thyroid hormones levels are normal. This one, you almost never get tested except in an endocrinologist office, because it's, first of all, it doesn't change treatment dramatically. And second, it's much harder to detect because it's in much lower levels because it's only high in that little portal vessel, right? So these 2 are usually relatively easy. Now, your doctor is not going to test you for them unless, of course, you're pregnant. All of us get our thyroid levels tested when we're first pregnant because, of course, thyroid problems during pregnancy can be major and they're not that hard to treat, right? But they're not going to test all that stuff on you unless you have a reason to test it. Like they're not going to, for instance, test your insulin levels or your thyroid levels or your cortisol levels unless you have something that makes you want to test it, right? So, but most of them, yes. Hormones are way, way easier to assess the level than are, for instance, neurotransmitters, in which they start dumping stuff into your head hole and see if it works. Right? I wonder if this will work. It'll be good. And let's stick an IUD up there too. Just like experimenting on you. And you're like, and then I died. Okay. Okay, so now the last part, and we will finish this on Thursday, but the last part, I'm not letting you go early, don't worry. So the last thing that we have to assess is to make sure that we understand the fizz of the feedback loops, right? Okay, so there's basically 3 different ways that you can tell when to start or stop secreting a hormone, and here they are, okay? Sometimes, so if you have the old set of notes, you're going to have to go past the signal transduction mechanisms to this, okay? So, because we already did those. Okay, so there's 3 ways for the hormone to feed back and tell you when you've got enough or too little or whatever, and they are these 3. Either a hormone itself can feed back, right? So T3 and T4 is the thing that feeds back, and it's that way there too, but it's not always that way. Sometimes it's a non-hormone substance, like a nutrient or an ion, that does the feeding back. Anybody think of an example of that one? A non-hormone substance that tells you when you have enough of the hormone. Insulin. Is it insulin that feeds back to the bloodstream, or is it glucose? Exactly. So hormone can feed back to tell you when you've got enough. Non-hormone substance, like a nutrient or ion, can feed back when you've got enough. And those make relatively easy pictures, right? Because this time it's just the glucose feeding back, right? The one that makes a hard picture is when it's the nervous system that's feeding back to tell you when you're not enough. Like this. I'm releasing epinephrine because there's a damn tiger in the room, right? Okay. And then when do I stop releasing epinephrine? When the tiger leaves, and I don't know how to draw a tiger leaving in the feedback loop. So you can draw. You've seen how well I can draw, right? It ain't impressive. So it is the nervous system, right? A different nervous system stimulus, right? So fight or flight versus no fight or flight, right? Or how about oxytocin? When do you release oxytocin? What? Labor and delivery, skin-to-skin contact, orgasm, breastfeeding, right? So when do you stop releasing it? When you're not in labor, when you're not having sex, when you're not touching anyone, and you're not breastfeeding. That's the feedback, right? It's a different nervous system input, okay? So those don't make good loops, but they do, conceptually, you can understand them. So there's 3 ways to basically know when to start or stop secreting a hormone. Hormone feeding back, the nutrient or ion feeding back, or the nervous system stimulation changes. Good? Okay. So what we have to do now is just make sure that we understand our hormones and where they fall into each of these. So again, this is not new information, just categorizing the information we've already learned. Okay, so the general truth is that you don't release constant amounts of hormones. You release them based on the body's needs, right? You don't always release the same amount of insulin or the same amount of estrogen or the same amount of cortisol, right? So you know that there has to be a feedback mechanism, right? And so negative feedback is the typical control mechanism. It's negative feedback that says, I got plenty, you're cool, I need more, whatever. And so the 3 types of hormone secretion are non-hormone substances. By the way, they call that humoral control because way back when they used to call all of the body fluids humors, like the aqueous humor, and they used to bleed you if your humors were out, right? So that's like a really antiquated term. So you got humoral control, which is non-hormone substances. You have hormonal control, which is hormones feeding back, right? And then you have neural control, which is the nervous system telling you, right? So I don't usually use the word humoral, but you will see it. You'll see it in patho, for instance. Okay, so let's look at a couple of examples. These are not going to be hard. It's not new information. Okay, so the one that you guys already told me is this. So I will show you, and then you are going to tell me with this one right here. Okay, this is an example of which of them? Non-hormone substance controlling, hormone controlling, or nervous system controlling? Yes. So this is like a humoral control example. It's classic, right? So the blood glucose level is too high. The beta cells of the pancreas release insulin. The cells throughout the body increase glucose uptake, which drops your glucose level, right? And it is not insulin. It is glucose that feeds back. Good? It's a classic non-hormone feedback mechanism. Now, this next one, I haven't taught you yet, but when I teach it to you now, all I want you to know is, can you see that it fits into this category, right? So with this one, I'm less worried about memorization, in part because it's only part of the aldosterone story. But let me tell you this part of the aldosterone story. This is one of the ways that aldosterone is regulated, which I haven't told you yet. the blood potassium level goes up, and then the adrenal cortex releases aldosterone, which causes the kidneys to pee out more potassium, right? Which drops your blood potassium, and then what feeds back to tell you that you have enough aldosterone? Potassium. So not did you know that one, but can you see that it fits into this category? Yeah, it fits into this category of this non-hormone substance. And then I'm going to tell you two more, and I want you to draw those feedback loops because they also fit into this category. And they are PTH and calcitonin. Do you know what the feedback thing is with PTH and calcitonin? Anybody know? It's calcium. It's calcium level, right? It's calcium that feeds back. Okay? Do you remember the calcitonin story? Calcitonin tones down your blood calcium, so calcium would be high. And then what organ would release calcitonin? Thyroid gland would release calcitonin, right? Which would go to the bone, among other places, right? Okay, and then cause you to store more calcium, drop your calcium level, and then calcium, low level of calcium feeds back. So PTH is kind of the opposite example. So you should be able to draw both of those little feedback loops. It just takes a second to think about it, and then you get it. Good? Okay, so those are all, you're just giving me a look like I don't know what you're doing. I don't know when you, okay. So I'm trying to say this is easy, and he is telling me you are obviously drunk. And I am not, because I will be tonight, though. I'm telling you, man, I don't know if I'll be celebrating or what. But my husband and I voted for two different people, so not like the worst two people, like the top two. We just had a slight difference in agreement on third-party candidates in this particular election. But it was a nice disagreement. My son was like, are you guys going to be okay because you're voting for two different people? I was like, I respect his position. And my husband was even like, do you really, really want me to change my vote? And I was like, I respect your thought process. I just came to a different conclusion. And my son, was like, really? You guys are okay? I was like, we're fine. There's a lot of politics talk in our house. Okay, so those are all of the great examples of non-hormone substance or humoral control. And then I'm pretty sure that you can think of some examples of hormones controlling other hormones. Like damn near anything that starts with the hypothalamus, right, is going to be hormones controlling other hormones. Does that make sense? You got a hormone that causes you to release a hormone that causes you to release another hormone, and then generally, not always, but generally it's that third hormone that feeds back. Where it feeds back depends on the chemistry of the hormone, right? Okay, it might just feed back to the anterior pituitary, it might feed all the way back. So the classic examples of hormones controlling secretion of other hormones is this whole thing. So all of the hypophysiotropic hormones. Classic example, if I were you, I would make damn sure that I know this one. Because every time I can't think of a question, I write a thyroid question. I'm like, I don't know, thyroid again, right? So I always think you know thyroid, and I think I'm being nice, right? I'm like, oh, thyroid's fine. The most common mistake that people make with thyroid is they forget that T3 and T4, especially when you're doing primary, secondary, tertiary, that these only count as one, right? So this is 1, right? 2, 3. If you count it as 1, 2, 3, you get it wrong. So just remember that those are together at the bottom. So T3, TRH, TSH, T3, T4, all of your reproductive hormones, both testosterone and estrogen, are regulated that way. Last little tidbit, and then we'll do nervous system next time because this is our whole stress physiology talk that we're going to do next time. So conceptually, does it make sense to you? I just want you to think about that damn hypothalamus for a minute. Does it make sense to you that the hypothalamus, in addition to being a nervous system structure, do you see that it has to have a boatload of hormone receptors? So do you see now why I started at the beginning of this set of notes? I said the hypothalamus is really the crossroads where the endocrine system and the nervous system come together. So it's getting input about like the metabolism and light and temperature and all of that kind of stuff. But in addition, it is also has boatloads of receptors for hormones. It's responding to hormone levels. Does that make sense? And it is basically integrating all of that information to try to decide, without ever asking your conscious brain, what to release and when. It is a really, really industrious little blob, right? It's like this little is like carrying the rest of it. It's like, I got this, dude. Got it, right? So the hypothalamus has nervous system and endocrine system inputs, and deciding like collectively what to do with those to decide. So we will stop there. We will do control of hormone secretion by nervous system next time. Good luck. I hope you have a good night. I'm going to be up all night. And hopefully it'll be over really fast. It'll be like, Florida's gone, Ohio's gone, everything's gone.